Madeline. I just want to thank everyone for coming out for this meeting. I know it's a long way to get here, but I'm sure you're okay. We'll start with the apologies first off. Madeline, do you want to do the apologies?
No apologies, Chair.
Lovely, none I've got either. The minutes of the previous meeting then. Let me bring that up. Had it around here somewhere. Okay, can I? Is everyone happy to accept those minutes?
I've got a couple of questions, Ken.
Okay.
On page 6, is it on the agenda? Yes. And I think that it was a question from Tony Lloyd to Charles, and the supplementary answer was saying yes, he agreed that there should be some sort of recognition of the heroism of staff and the GPs in the early stages of the outbreak. And Charles said yes, actively discussing at the moment as to what the best way to actually recognise this is, and fully agreed. So I just wanted to know if there was any progress, because that was a couple of months ago.
Not that I've heard of.
If nobody knows the answer to the question, can we ask it and report back next time?
I'll follow up for you.
Chase him up, see if he has got anywhere with it. I'm sure he has. A little bit busy for some reason at the moment. I think that's all right. Any other amendments to those minutes or notes on those minutes?
No, not so much an amendment, but I'd like a copy if I can, please, Ken.
Oh, okay.
Jim Frode, I've not got one at the moment.
Okay, Madeline, if you could arrange a copy for Jim on them. It's just the minutes you haven't got on the agenda.
Yeah, I haven't got the minutes or anything for tonight's meeting other than the briefing that was sent out today.
Ah, okay.
The Health Watch report.
I'm actually in the same situation as Jim. I've received nothing other than the reports previously sent out.
Okay.
I couldn't find an email from Maddie, so I just went onto the website and used the publicly available page.
That was a good thing.
In that case,
yeah, that's what I'm doing, but
maybe
well.
it's gone adrift then, because there's quite a few of you. So, yeah, I don't know. Madeline will be able to sort that out, I'm sure. Do you want a copy of the agenda resent to you, or are you just going to play it as is at the moment? Everyone happy just to continue? Yeah,
I'm happy to play it as is at the moment.
Right.
And I got another question on the minutes. So on page 8, second to last question, I asked a question which was basically saying WBC staff had done a fantastic job dealing with the pandemic. Those who have been redeployed, those who have helped with the food hub at St Crispin's and assisting in care homes. And I propose that the committee formally recognise their hard work. Has that been done?
All I'm seeing is the. What page was that, Clive?
Page 8.
Which paragraph would that have been? Oh, at the very bottom. No. Which paragraph?
Second to last paragraph.
Councillor Jones. Oh, I see it. Was that not done at that time? And what do you call a formal recommendation?
Yeah, propose that we formally recognise their hard work. So I think at least they should get a letter maybe from you saying that this committee recognises their hard work and thanks them for it. A nice letter.
I can't see a
It goes a
problem.
long way when you've been putting yourself out for quite a few months.
Yeah, no, I can't see a
So-
problem with that at all.
To get a letter along those lines.
Yeah, so they're recognised to be seen doing these things. Oh, excuse me. Oh yeah, is Madeline still there? If we can get No, that's okay, Madeline. Don't say anything. Yeah, if you could arrange for something to be drafted up, and we'll get that out to the necessary people or publicised in some way. Thank you, Clive. Cheers.
Okay, thanks. That's it for me.
Okay. Anyone else? Any comments on the minutes? Okay, we move on now then to declarations of interest. Has anyone got a declaration of interest they wish to make? No. Excellent.
Yes, I might have to make a declaration of interest
Okay.
because I have just been elected to the Board of Governors of the Royal Berkshire Foundation Trust.
Ah,
I don't know if it's for 3 years or for 1 year. I have to wait and see, and I'm not exactly sure when I take up the post, but I think it's November.
right. Oh, so you're not actually on the board at this moment, so
No.
that's not going to be a problem then, I don't think.
Okay.
But that's certainly something we'll work out for the future, see how that fits in.
Congratulations, Clive.
Thank you.
We now move on to the public question time. I don't think there's any public questions. No.
No, Chair.
Oh, thank you. Member question time.
No, Chair.
Lovely, great. Okay. Before we actually
Sorry,
get,
Ken, I thought that Councillor Cowan had put in a member question for this committee. Am I wrong?
not that I've seen.
Not that I've been informed.
Okay.
No.
I'll just check on that one.
Well, there's no question anyway. But
Carry on.
Sorry, can I interrupt?
Yeah.
I just got a text from Rachel Bishop Firth saying she was knocked out of this meeting. Did anybody do that, or was it just her local laptop or something?
Yeah, we don't lock people out of the meetings unless.
Okay, I'll tell her to reboot. Okay.
Yeah.
Trying to get back
I
in.
saw her and then she disappeared and passed. Don't know what's going on there, but none of us here have the administrative permissions to do that. The only people who would, I presume, would be effectively Callum or Anne. No member should anyway.
Thanks, Callum.
Okay.
Yeah, she's restarting.
Jim, I've got your hands up at the moment. Is there anything you want to say?
Yes, Ken. I have an email from Councillor Cowan, which is titled "Member Question for the Chair of the Health and Overview Scrutiny Committee to be held virtually on tonight." I've only got a copy of it. I'm not sure how it's sent it in, but I'm not sure what's happened with that.
When was it sent in? What was the time and date on the email?
Sorry, I can't hear.
Date on the email?
I got it on the 11th of September.
Again, Chair, it's Callum. I'm not sure if Anne is there, but correct me if I'm wrong, Anne. I believe this question was received, if it's the question I'm thinking of, but it was rejected as it didn't meet the criteria for a member question.
I did speak to Councillor Cowan about this, and he assured me that he'd already been received the information, and therefore he wasn't going to take that forward. If that was
sorry, Anne. Yeah, he just copied me, and not on any of the subsequent actions. Hence the confusion.
Yeah.
Not unusual. Thank you.
All right, that's lovely. Now, before we go into the rest of the agenda, I was just going to suggest that because we haven't got a representative from the dental services arena coming forward. I'm going to move number 19 to probably the end of the meeting. I think it might just be we'll see what Health Watch say when they're here, but we might move it to after Health Watch or just before Health Watch, depending on whether they want to hear what we say about agenda item 19. So on that note, we'll now go to the first item on the agenda, which is 18. And this was pharmacy services, and it's Kevin Barnes, I think, is it?
Yes, hi, good afternoon, or good evening, everyone.
Okay.
I'd just also like to introduce David Dean. David's with me, and David will be going through the presentation, but we'll be doing it together. We represent Thames Valley LPC. I'm a contractor support officer, and David is the chief officer for the Thames Valley LPC.
Wonderful. Okay, well, please go ahead. Yeah.
Thank you very much, David.
Yeah, is the presentation going to be shared, Kevin, or?
Let me try and get it for you now. Can I share? Let me just see from here.
I'm sure you can, because I know Callum's here.
Let me see if I can share it. So my IT skills are limited. You can see that now. I can't see if I can share it. I've got it in front of me. Share. I've got it here. That's it. Can you see it there?
That's it. We're
Yeah,
seeing
it's
something.
through.
Yeah, we
It's
go.
appearing, yeah. Thank you for that, Kevin.
No problem at all.
Yes, I thought this was a great opportunity to actually introduce who we actually are, because I'm not sure that many of you actually understand who the LPC is. So, Kevin, go to the next slide, please. Next slide. There,
Cool,
thank
there we
you. Oh, too far. That's it.
Too
Thank
far.
you. One more.
Yeah, there's the first. There's the one there.
That's it. Thank.
Yep.
Stop. There you go. Right. So we basically are a statutory body. We represent all the community pharmacists in Thames Valley. So that's Oxfordshire and Berkshire, obviously including Wokingham. We're an independent representative group, so we're a non-profit. We don't sell anything. We don't buy anything. There's a very, very tiny percentage of every single prescription goes towards our upkeep. And some of the money from those funds go towards our national negotiating committee that actually works with the Department of Health and NHS to make sure that we organise national services. So things like the flu season would have been negotiated at that level. But the LPC works locally with the NHS England area teams, CCGs, local authorities and our healthcare colleagues, so we can hopefully deliver the best healthcare services for this community.
Okay.
Bit of a time delay, isn't there? There you go. So what we try and do is understand what the needs are of the local community and negotiate with commissioners to try and deliver the services that we're allowed to make sure that we generate great patient outcomes. We also work quite closely with the LMC so that GPs and pharmacists can work together. And a great example of that would be during the current pandemic and planning now for the flu season. There you go. So I think just very briefly, I think the three big advantages of community pharmacy would be accessibility. Now, during the whole coronavirus pandemic, pharmacies remained open. Obviously not 100% of the time because there was issues with staffing and accessibility in terms of queues of people trying to descend on some pharmacies and obviously trying to keep the patients and the staff safe. But I think 95% of all pharmacies remained constantly open throughout the whole pandemic, and continue to provide many services for local patients. And community is a massive part of what we try and do in pharmacy. We do have national services, but we do try and make sure that local patients get the services that they deserve. And I think you'd probably agree with me that all local pharmacies really understand and know their local patients. And I've worked in many pharmacies where as soon as a patient walks through the door, they know exactly who they are, what medication they're on. And if they're looking a bit peaky, they may notice and hopefully have a conversation with that patient. And again, the great thing about pharmacy is the advice that professionals can offer to patients. Again, we're quite proud of the fact that, you know, the training for a pharmacist and a member of staff who works in pharmacy is quite rigorous, and we continue to deliver fantastic advice and services whenever the need may be. So there's 264 pharmacies in Thames Valley, and 72 of those are in Berkshire West. We have a very, very small team, so just myself and Kevin, so you got 2/3 of it tonight. And then my wife works part-time as our sort of admin engagement social media officer to make sure we try and get those messages out to our local patients. And obviously attending meetings like this one, and we do many with Health Watch and other organisations. One of our sort of things that we try and do in our constitution is make sure that pharmacy is represented and considered a value in society and the local community in providing those services. So, to be honest, I haven't seen the agenda in terms of pharmacy services, but me and Kevin are here to hope to provide any answers to any questions you may have about COVID and potentially flu and the COVID vaccination going forward. So thank you.
That's lovely. Thank you very much for that. It certainly was a clear presentation. Shall we go around and see who's got questions? I currently can see Jim, your hand's up first.
Oh, I see. Hands up.
Thank you. Can you see your hair?
Yes, hello, Jim.
Cancel the slideshow now.
The slide's still up at the moment, I think. Okay. Thank you for that. I've got a couple of questions, if I can. Firstly, can you just give us a summary of how COVID has affected the pharmacy industry and its your members? 2, what's your involvement with track and trace? And 3, what planning are you doing for when, hopefully, we finally get the vaccine?
Okay, first question first. In terms of how it affected us, I think, like everybody, we were taken by surprise in terms of the lockdown and the response by the public in terms of getting their medication. And I think overwhelmed is a word I would use at the very beginning. Several scripts were presented to pharmacies in 3-4 times the quantities they would normally be presented. And that caused several issues. Obviously, it slowed everything down because it takes 3 or 4 times longer to put together a prescription, 4 prescriptions rather than just 1. And then that caused massive issues in terms of supply chain for medicines. And of course, if you think about pharmacies, a lot of very, very small businesses with teams of maybe 4 to 8 people, and with lockdown, kids not being able to go to school, and of course illness, several pharmacies were very badly hit in terms of manpower, but they battled on, and I think they responded heroically along with the rest of the NHS. And when we got to sort of April, May, a lot of the first initial issues were ironed out, and they've continued to deliver excellent services. And to be honest, they've been working flat out. in terms of delivering services, but they've been badly let down by the national government, to be honest, in terms of funding. Pharmacy has been given a total of £300 per pharmacy for COVID funds to pay for plastic screens to put up in each pharmacy. The pharmacy funding model is very, very complicated. So if you think about every time a prescription is presented in a pharmacy, the pharmacist has had to pay for that stock ahead and only gets paid 3 months after that prescription is presented to the NHS. So because of the increased demand in prescriptions, many pharmacies are now heavily in debt. The government have advanced pharmacies about 2 months worth of funds, but at this moment in time, they want that money back. And my concern is that we will lose several pharmacies across England in the next few months. In Oxfordshire, we've lost 5% of all pharmacies in the last 4 months due to several financial pressures. But as it stands now, pharmacy is in a good place in terms of preparedness. We have no connection whatsoever with test and trace. In fact, we are as frustrated as everybody else, as if we have a case in a pharmacy, if test and trace is inaccessible, then there's a risk that pharmacy will close until they get replacement staff or whatever. And in terms of preparedness, we've been working now flat out for months and months and months, expecting a second wave, expecting a very, very strong flu season. And we've delivered 20,000 vaccines in the first 2.5 weeks, which is about twice what we normally do. So potentially there could be a supply issue there in terms of flu vaccinations. But the government has promised us extra vaccinations for later in the year. And in terms of the COVID vaccine, we don't know when. We're thinking perhaps January. And pharmacy will be on the front line along with hospitals and GPs and nurses and anyone else that can hold a needle, to be honest, to vaccinate the general public when the vaccine is available.
Thank you. I guess one follow-up question maybe for later on is what can we as a council do to help you? But I'll leave that to after the rest of the questions.
Thank you.
Sorry about that. I had my microphone muted. Kevin, can I just ask you to cancel the slideshow that you've got open? It's
Oh, so I thought I had cancelled. Sorry about that.
it's not disconnected from the screen yet.
I'll close it down totally. Is it off now?
Yes, there we go. Thank you very much.
Okay.
I'm going to go on to Rachel. I'm glad to see you managed to get back onto the system. Do you have a question?
Yes, I do. How are you set up for flu vaccinations this year? Because that's likely to be quite critical, particularly for people in care homes.
Yeah, Kevin, do you want to take that one?
Certainly. Okay, so as David mentioned early on, we've done about 20% of our flu vaccinations already, of which about 86% of them are over 65s. I don't have all the information yet on which care homes, which is private, which are walk-ins into a pharmacy and which is care homes, but that breakdown will come through in the next couple of days. But to say, majority are over 65s, 86% of those.
Yeah, in terms of care homes, the GPs take primary responsibility for delivering vaccinations to residents, and pharmacy are there as a backup plan. But one thing that is slightly different this year, we're trying to encourage 100% of all care home staff to go and get their vaccination at their GP or a pharmacy. And that's one thing we could do with your help on, actually, because as a local authority, you've got a hotline into all these care homes, and the care home managers need to take responsibility and ensure their staff go for their vaccinations. Only half the staff got vaccinated last year.
Do care home staff get free flu jabs?
They do.
Yeah.
As do all domestic carers as well.
Right, okay.
And in addition to, there's new groups this year, so all shielded patients get free vaccination, so those that are officially shielded on the GP's list, but also all those that live in the same household as well.
Right, okay. So that, if that is something that maybe Woking Borough Council's PR department could push out communications, that would be very valuable for the general population. And then, as you say, we've got a route into the care homes through those links.
Yeah, so I dropped a press release to TV, radio, newspapers last week, and I managed to get a little bit of coverage around the new groups. But any help that you can offer would be fantastic. Thank you.
Okay, fantastic. Thank you very much.
Okay, no problem. Clive, over to you.
Thank you, Ken. What you said earlier, David, about pharmacists knowing their customers very well, certainly was the case at my local pharmacist. Every time I walked in, the lady was having a chat, and she was very, very friendly. Sadly, she left to become a locum because it fitted in more with her lifestyle and that sort of stuff. And ever since she left, you hardly get a word out of the pharmacist that's replaced her.
Well, I can't teach them bedside manners, but if you want to, if you want to drop myself or Kevin a line with, with the name of the pharmacy, anything we can help, that's what we're here to do. Yeah, we are a bit of a, not a mediation service, but we can be a bit of a bridge builder sometimes. Yeah,
I won't mention it on this call, but it is a chain, and I've actually dealt with the chain several times, and they have been very, very good. I've got another question. A few years ago, there was a real problem with pharmacies closing, and you've just said that 5% of those in Oxfordshire have closed in the last 4 months. I haven't noticed any around Wokingham.
No, none in Wokingham yet.
I haven't been too far out of Early where I live, so and we haven't had any closing. So you're just saying
Lloyd's in Woodley closed in February.
Did they? Right. But we haven't had too many close.
No. But I didn't want to be a doom monger, but you need to understand that financially, like any other business in the UK at the moment, pharmacies are under tremendous pressure.
Yeah.
But obviously, I'm sure that no one wants to lose their local community pharmacy.
No.
But that's a real concern, and something I've tried to speak to, written to all the MPs, and to be honest, the response was very poor. Theresa May was fantastic. She's my local MP, luckily enough, so she responded to me. And the CCGs have been very, very supportive.
But funding is very complicated, isn't it?
Exceedingly complicated, and it's been the same funding now for 6 years in a row.
No increase?
Not a penny.
Really? That's pretty poor, isn't it? Not acceptable, really.
Yeah.
Okay. There's probably nothing we can do about that, is there?
Unfortunately not. It's our money, but we don't get that much of a choice about what happens to it. But it's something we've spoken to Matt Hancock about and to Boris. So,
all right,
we will continue.
Okay, thank you.
Thank you, Clive. Next on my list is Abdul. Would you like to ask your question? Oh. Abdul, are you there? I'll tell you what, we'll move on to Alex. Hang on.
Ken, can you hear me now?
Yes, I can hear you.
Ken? Oh, good evening. Thank you, Chair. Sorry, I had a bit of complication with my iPad today. My question is related to demand and supply. So it sounds like we are okay in Wokingham. However, out of 72 pharmacies in Berkshire, how many do we have in Wokingham? And if those small ones seem to be, out of business, going out of business sooner or later, are we able to cope with the future demand?
I couldn't tell you how many specifically in Wokingham. Kevin will probably look it up for me in a minute. the problem we've got is that the whole way in which people are getting their prescriptions is changing. There's a big push by some of the larger companies, quite rightly, because that's a different way of doing things, to send a lot of prescriptions online, which of course helps those people that have accessibility to technology and to apps and everything else. But one thing that can't do for the community is deliver things like flu vaccinations. You can't do those by the internet at the moment. You can't go and get advice about a prescription that you think you're having an adverse reaction to the medication. You can't get advice for your baby when it's got a fever as easy as you can online. Harder to do it online than it is in person. So we need to be supportive of our local pharmacies, but if they do disappear, there is little or no chance they will come back.
Right. My other worries about our elderly generation, they are not online.
Correct.
How they're going to cope with it?
Indeed, which is why we need to continue to support community pharmacy.
Okay, going back to your contractors, how do you work with them? Is there any way that we can put pressures or ask them to put more time into small pharmacies than Sainsbury or Asda, the bigger ones?
Well, we represent all the contractors, so whether they're Boots, Lloyds, Asda, Morrison's, Tesco, whoever they are, or Mr. Smith has got a tiny pharmacy on a high street in Wokingham somewhere, and we represent them all their owners, and nobody goes out of their way to not do the best thing they can for their community, and the LPC is here to help and support and to coach a lot of those owners and contractors, even the big boys, because myself and Kevin have both worked for Lloyds, and I've worked for Boots as well, so we understand how they work and what makes them tick. So we do what we can to try to make sure that they get the best out of their pharmacies in the local community. But sometimes decisions are made at a much higher level, or financially just there's absolutely no flexibility at all, and those businesses go.
All right. Thank you, David. I'll come back to you.
Thank you. But if you want to drop your line privately about anything you worry about, then please do so.
Thank you.
And so, Chair, there's 21 pharmacies in Wokingham.
Okay.
Thank you, Kevin.
Alison Swaddle next.
Thank you, Chair.
Hi.
I wanted to ask, are pharmacists considered key workers for getting a priority test, COVID test?
Yes, they are. I mean, it was very early on. They weren't considered key workers by supermarkets to get food, but we got there in the end. But yes, very much so. We're not employed directly by the NHS, much like GPs, and many pharmacies are private businesses, but they deliver NHS services, and a prescription is an NHS service, as is a flu vaccine. But yes, they are regarded as key workers.
So how has the situation been over the pandemic? Because obviously a pharmacy cannot be open without a registered pharmacist. Is registered?
Correct.
Right? Yeah. On the premises. I mean, do we have many pharmacists who can provide cover?
Yes, we have a locum population, very healthy locum population. I think Clive pointed out that one of his favourite pharmacists is now a locum. Yes. And we've been exceedingly lucky. We haven't. I'm touching my dining room table now. We haven't lost a pharmacy due to COVID at this moment in time for any length of time. We've lost them for the odd hour here and there to allow them to catch up. But touch wood, so far we've been very, very lucky. And we need to make sure, obviously, that pharmacists and pharmacy teams are given all the support they need. So PPE was an issue a while ago, but it isn't now. So we need to make sure they continue to be protected, and some of them will still restrict patients coming into their pharmacies to make sure they keep themselves protected so they can continue to work.
That's right. I mean, I think a distance queue is probably always a good idea to pharmacists.
Yeah, it was quite difficult early on. We had some complaints early on from several members of the public about queuing, and quite understandably, some of the queues were quite long and took quite a while to get to the front to get your prescription, but it was seen as necessary at the time. But I think things have calmed down a little bit now, and I just want to say thank you actually to the local volunteer groups in Wokingham. They really helped us out big time in terms of delivering prescriptions to the local population in Wokingham. Kevin worked exceedingly hard with several councillors and local volunteer groups to make sure that happened. So without you, we couldn't have existed during it, to be honest. So thank you.
Yeah, I know in Woodley we've got an absolutely amazing, very large team, the Woodley COVID response.
Absolutely.
And people have been saying, you know, in the recent weeks that they're all ready to step up and be there for their neighbours just the same. But thank you very much for everything that you're doing.
Thank you.
Thank you, Alison. Last one is Adrian.
Thank you, Chair. Firstly, David, thanks a lot for coming in, and your colleague Kevin. Really appreciate it. You know, I think we need to have more regular meetings than once a lifetime or something. There's been a number of questions over, I would say, the last 18 months around nomad packs. Yes. I think you know, this is a service that is massively appreciated by the residents, and some of whom the nomad packs are absolutely critical to. So there would definitely be resident concern that you know, pharmacies were pulling this service effectively. Would you like to comment on that?
Yes, and Kevin has been working very hard on this actually with local CCG. So we need to understand that the making up of a tray, a blister pack, if you like, with medication in it is a very complicated and laborious process. And we need to make sure that those patients that need that service continue to get it. I would suggest, though, there may be some patients that get them that don't actually need them. And when they had a chat with a health worker many moons ago, all the other options weren't discussed. So things like large print labels, easy to open bottles, braille labels, all sorts of extra things we can do in a pharmacy to make sure that patient can understand the medication they're getting. Alongside that, the advice by NICE and the Royal Pharmaceutical Society and our head body is that medicines don't really do very well in blister packs. As soon as you take them out the original packing, you can't really guarantee their efficacy because you've changed the environment in which they're stored. So it's a combination of making sure we do a quality assessment in every pharmacy to make sure that every patient that needs and deserves a tray continues to get one. But we need also, on the other hand, to make sure that those that don't need them don't get them, because there just isn't enough capacity in pharmacy to make trays for everybody.
That's a very good response. Thank you for the comprehensive nature of the response. I think the request is, you know, if we get a resident complaining specifically, can we come back to you and ask for an assessment?
Every community pharmacist has the access to an assessment form. And in fact, just this last week, Kevin has put together a pack for contractors to help them make that sort of decision. We also need to understand that there is no funding from the government to do a nomad, a tray for a patient. It's purely done on a goodwill basis, as is the other thorny subject of free deliveries of prescriptions.
Yeah.
There is no fee payable by the government to allow pharmacies to do that. And pharmacies have been doing that for years and years and years. And some of them now are having to rein that in a little bit. But we will work with yourselves and the local community and GPs and social care to make sure if we all agree that that patient needs a tray, they will get one.
Yeah, that's really helpful and kind of you. Thank you. One of my big questions was going to be around funding, but you already explained in a sense that point. You there's been no increase in funding for 6 years, etc., etc. But where is your funding actually coming from? Does it come from the CCG or somewhere else, or NHS England, or?
It's the Department of Health. So we receive something like 2.8 billion in England, and that pays for all the prescriptions and all the services that pharmacies receive. And that hasn't changed for 6 years.
Yeah. Okay. What? I'm very confused with the where we're going with all this, because the government is regularly saying don't visit your GP, go to your pharmacist.
Correct.
On the one hand, and then actually restricting funding to pharmacy, so that pharmacies, like in your example, 5% have disappeared in the last X months. How does this line up? It seems to be contradictory. You cannot remove layers and tell people don't talk to your GP, talk to your pharmacist, and then get rid of your pharmacist. It's not making any sense to me.
So that big pot of money, the £2.78 billion, has remained the same. What the government has done is moved money around inside that pot. So it's taken money away from one service and given it to another. So there's some exciting services coming up. So there's going to be I don't know if you know, but if you ring 111 now, you might get referred to a pharmacy. And pharmacies will get a small amount of money if you go in, have a discussion with the pharmacist, and then you either buy something off the counter or you get emergency medication. The same service is going to kick off later in the year for GPs. So GPs are going to be able to refer patients directly to a pharmacy using a national sort of template. And that's needed, obviously, because GPs are unfortunately having to not see as many patients at the moment, and pharmacies are well placed. And I've talked about accessibility, and that's a major sort of advantage of being in a pharmacy. But there's no extra money for that. That's all coming from that same pot of money that they've just moved around, swishing it around and distributed it differently.
Thank you very much, David. No further question.
Thank you.
Okay, I can't see any more hands up. I think that's the end of the questions. One other thing I'd like to ask is, if someone asked me how do I contact someone to speak about pharmacies in general, I don't know what I tell them to get across to you. Would just use the internet, or is there a telephone number you can ring, or is there?
Well, we have our own website, so pharmacythamesvalley.org.uk, and it's all there. It's a public website.
Google it would come up anyway.
Absolutely, yeah.
Okay. So I'll make the assumption whoever I speak to will have access to the internet, but I'll probably Google it myself first.
Yeah, I have a telephone as well, just in case.
Yeah. But David, thank you very much for that.
You're welcome. Anytime.
That was very interesting, actually. There's a lot of new things in there that I don't think we've come across before. So it's a good thing to be speaking to you.
I'm happy to do this on a regular basis, so just ask.
Okay. We'll
that
check.
would definitely be an ask, yeah, from my side.
Good.
Yeah, I think probably once every 6 months or something. I suppose it depends on how things change, isn't it? With COVID, it's so key. It's high on the interest list and lots of questions. So yeah, that sounds good to me anyway. So yes, thank you very much, Kevin. Thank you very much, especially for the slide presentations, and look forward to seeing you again.
Thank you.
Thank you, guys.
Thanks very much.
Thank you,
David.
David.
Thank you.
Okay, we're going to now move on to skipping 19. We're going to move on to the Building Berkshire Together, agenda item 20.
Chair, Rachel's got her hand up.
Yes.
Oh,
Thanks very much. I'm really sorry I missed a big chunk of the beginning of the meeting because my technology failed. And I just wanted to say, can I have the same interest that I declared last time, my father being in a father-in-law rather being in a care home, locally rolled over to this agenda? I also had a number of questions on what we discussed last time, which if you prefer, I can send in to Madeline. They may well have been raised by others. And be noted anyway, but if shall I send those into Madeline?
I think that'll be best.
Yeah,
Yes.
fantastic. Thank you very much.
Your interest is noted as well, so that's fine.
That's great. Thank you.
And we're now going across to Nikki Lloyd, I believe.
Hello, Ken. Thank you so much, committee, for inviting us to join you this evening. My name's Nikki Lloyd. I'm Acting Chief Executive at the Royal Berkshire NHS Foundation Trust. You may know the substantive Chief Executive, Steve McManus. He's actually on secondment until February with Test and Trace. So I'm in the hot seat until February, but thank you very much indeed for inviting me to join you this evening. I'm also joined by my colleague, Victoria Parker, who is our Director of Communications. And Victoria will be running through the brief slide deck that we've circulated to the committee beforehand. I would just like to say a few words before Victoria gets started on our presentation, though, really just to echo the comments following the first presentation around how the community and volunteers supported NHS organisations and especially our own during the recent pandemic. And I'm sure colleagues around the table this evening will know of or may have even been involved themselves in one of the many activities that helped support our staff. So we had colleagues brought in food so staff could have hot food breaks. We had donations of chocolate eggs. We had volunteers sewing scrubs for our staff, so they had extra changes of clothes. We were able to use local schools. A bus service was provided by one of the local schools, and we set up a temporary hotel facility and a pop-up shop on Reading School's ground. And I mean, there are too many countless others to mention. Particularly, we were supported by folks delivering pharmacy prescriptions for our patients when we moved to virtual clinics. So I'd just echo the earlier speakers about how the community came together, and would just like to thank everyone who's been involved, because we wouldn't have made it without their help. So thank you very much if you were involved in that, or you know people who were. The reason we're here this evening, as you may have heard, is to share with you our Building Berkshire Together, our site development programme. It's a once in a generation opportunity for us, and the Health Overview and Scrutiny Committee, I think, has a very special place in the development of our plans. You are the people who oversee what we do, and I see you as our critical friends to help us be better all the time. So I'm going to hand over to Victoria, who's going to take us through the slide deck. Madeline, I'm not sure whether you can share your screen. I think because we're guests, we're not able to do that. So I was hoping you might be able to share your screen with the slide deck so that we can talk through those as they come up, if that's all right.
I think we probably could if Callum is able to.
Can I just say that as a guest, you will be able to share your screen. There shouldn't be any reason why you can't.
Ah.
Oh, okay. In that case, Victoria, would you like to share your screen?
So I don't have them on screen because I was informed that they would be on screen for members. So I've not downloaded them, Nick.
Okay, well, I will just go and do that. So I'm guessing they came out to colleagues today. Have you got them?
We've got them. They're on screen. Perfect. Thank you. Thank you, Madeline.
So Victoria, would you like to to go?
So again, thank you, Chair. Thank you, esteemed colleagues. It's a real privilege to be here this evening with you to share this very, very exciting project for us. For those of you that have been inside, particularly the Royal Berkshire main building in Reading recently, you will understand why we're so excited about the possibility of receiving monies to develop, first of all, our strategic outline case, which is where we're at the moment. And I'll go through that a bit more in a moment. which will then, if we get that through the Treasury and the Department of Health and Social Care, we then move on to an outline business case where we get down into more of the detail and more of the engagement with our communities and our key stakeholders, of which obviously you are one, and then into our full business case. So this is over a period of years, but where we are at the moment, Madeline, if you could move on to the second slide, please. So we were part of the government health infrastructure plan. There was funding for 40 new projects. You might remember that the Prime Minister and Cabinet colleagues announced this some time ago. We are one of 21 trusts in this particular cohort to receive what we refer to as seed funding. So we had a very generous £2 million to develop our ideas that would go into the strategic outline case. And where we are at the moment is we've got quite a few possibilities on the table. In fact, nothing is really off the table at this point, I beg your pardon. And it's an opportunity for us, our local communities, our staff, our patients, and everybody to help us develop what we hope would be an absolutely totally refurbished organisation, either on our site or on another site. But again, I'll talk about that a little more. Madeline, next slide, please. So what we've done is we've outlined the case for change, and we refer to this as our 5 C's. We all like a model, don't we? And we all like a bit of alliteration. And so we've come up with the 5 C's, which describes the reasons behind why we feel that we are a worthy cause to receive the additional funding to go forward into an outline business case. So we start with condition. And as I said, those of you that have had the privilege to come on to our hospital, and it is a privilege because we like to think that we're very open and welcoming and that we provide the highest quality care for our patients. However, the condition of our buildings and the fabric of our buildings isn't what we would like to be delivering our treatment and care from. You'll know that many parts of the organisation started back in the 19th century. So 1839, I think we opened our doors, and you will see some of those rooms and some of those clinics and walls and pipework and roof spaces, etc. In fact, when we had a visit from the CQC recently, whilst they applauded the care that is given by our very dedicated staff, they did have a concern over some of the condition of the buildings that we have to operate out of. The next one is capacity, and we know that we don't have sufficient capacity. We know that the demographic is growing. People are thankfully getting older, living longer, but that does mean that we have more people to treat in and around our buildings. And we want to make sure that we have a building that's fit for the future needs of our local population. And then capability, it is a great place to work, but it could be better, and redevelopment will create an opportunity to create world-class training and development opportunities for our workforce. And as an anchor institution, we really want to welcome people in through apprenticeships, to be providing more jobs and to be encouraging people to come volunteer with us too. We hope that once we have a building that is a little, dare I say, smarter than it currently is, that will help attract top talent and retain our great staff. Our climate, well, we are absolutely, and Nikki will talk about this a little in a moment, we're absolutely committed to the green agenda, and we are heavily into sustainability within the Royal Berkshire Foundation Trust, but our current estate is not environmentally friendly. I mentioned the pipework, I mentioned the leaking roofs. Our heating, electrical and other infrastructure systems are outdated, they're expensive to maintain, and they're environmentally unsustainable. So we need to develop an estate with buildings that not only provide all of that infrastructure, but also have green spaces around to improve the quality of our environment and reduce our carbon emissions. And finally, the catalyst. What we want to, as I talked about, being an anchor institution, we have a real ambition to grow our strategic partnerships and to play a real part in economic growth in our communities. We need new facilities for patients who require hospital care, coupled with new technology to ensure that patients need to travel less. We will talk a little more about our outpatient agenda and ensure that we can get people in for routine tests and examinations on all 6 of our sites, not just at the site in Reading, but also that we do things differently to support the care closer to home agenda. Madeline, next slide, please, which I think I've probably outlined all of this. This just goes over what I've just talked about, so we can go on to slide 6, which talks about exploring the possibilities. So I talked a little about the strategic outline. Sorry, back one. Sorry, Madeline. Just back a slide. That's it. Yeah. So the exploring the possibilities, the what, the when, and the how. On one, sorry, I know it's difficult when someone else is talking to us. Like, that's it, that's the one. Thank you. So we're at the strategic outline case at the moment, and we've been informed by the ONS population data. We've been receiving considerable engagement input from our local communities through our digital platform, which I will talk about in a little. We've had a lot of engagement from our clinicians, from our porters, from our physios. Been doing a lot of work internally to get everybody to help us build this literally and metaphorically from the ground up. Thanks, Madeline. Next slide. So the possible scenarios are, and we haven't decided on any of this yet. These really are all still on the table, and it is all going to be down to the size of the envelope that we're awarded if and when we get through the strategic outline case to the outline business case. But some of what we're looking at is just general refurbishment and real rebuilding on the existing site. As I said, there are parts of the organisation, parts of the buildings that really aren't fit for purpose and could do with completely razing to the ground and a rebuild. Some refurbishment and substantial rebuilding on the current site. And that would be the step on from the first bullet point. So doing a little more than the tinkering around the edges. One of the other things we're looking at is a completely new hospital on the current site, which obviously would involve considerable upheaval to current services. It would literally be about decanting services to other parts of the hospital while we raise that to the ground, and then we rebuild, and then we move back. So you can imagine how that's going to impact on people that need to work and to use our service. The other options is a completely new hospital on a greenfield or brownfield site. And again, haven't identified that, but that would need to be out for public consultation. We would want to have adjacencies still with the University of Reading, who are one of our key partners, and we'd have to look at travel plans too. And then finally, other partial or additional scenarios based on those that I've just outlined. Thanks, Madeline. Next slide. Thank you. So I talked a little bit about adjacencies, and I talked about the University of Reading, but also we look at the Life Sciences Park in the Thames Valley. We have existing relationships with some of the organisations there. We need to look at the economy, we need to look at the speed, the compliance of all of this, the cost of it, and the convenience and the inconvenience to both our patients, our staff, and our key partners. Next slide. So where we're at the moment is, as you can tell, we're here with you this evening, but also engagement with other key stakeholders in and around Berkshire West, which is our geography, identifying the unique features that we have as an organisation, which I talked a little about, the Life Sciences Park, development of a strategic outline case, which is where we are at the moment. That's going to be delivered in the autumn once we've been around our whole raft of partners and organisations to discuss all of this. And those of you that do know about our Vision 2025, that was established a couple of years ago and talks about our people strategy, our clinical strategy, our workforce, etc. But to ensure that whatever it is that we come up with for the strategic outline case is fully aligned with that. Next slide, please. So this is our engagement microsite. This was developed, I think, about 2 months ago. We put it out to all key partners and to the public, to our governors, to our members, and we're getting a really good broad brush, rich picture of what people want to see in what will essentially be their new hospital, whether that's going to be on the Royal Berkshire site as it currently is, or on the greenfield or brownfield site as I described earlier. But we've had about 3,000, I think it is, visits to the site thus far, and of those 3,000, about 10% have converted into people for filling in our survey, which gives us an idea of what people do and don't want, the views and opinions of everybody that's interested in this. And actually, I was speaking to Nikki earlier today. In the last couple of days, we're getting a lot of comments and a lot of opinions coming through on what people would and don't want to see, and would and don't want us to do with what essentially people feel is their hospital. And I think as an anchor institution, we really do feel that we are an essential part of the community. And whilst some of us are privileged to work within those walls and within that boundary, we do feel that this is very much a community asset, and therefore we have to take that into full consideration. I think that's the last slide, Madeline, or is there one more? Okay, so this just gives you the URL of how to access the microsite and to make comments and to leave your views. There's a public forum on there where we're getting quite a good conversation going. So if you do have time and you do have an interest in this, as I'm sure you do, then please do get involved. And I think that's all I have to say. That was a gallop through, and I apologise for going so fast on this, but I realise you've got quite a big agenda and we're already at 8 o'clock. So I just wanted to get that. And I know that you have the slides, so you can look at them at your leisure, and I'm sure Nikki and I can answer any questions.
Victoria, thank you so much for that. That's very interesting. Back of my head, I'm hoping you don't get everything. I can't imagine the turmoil it would create if you had to do all those things. But yes. I'll move across to questions from the members now. Got a few. We've got Clive Jones first.
Thank you, Ken. I should have declared an interest other than becoming a governor, because I have a family member who works at the hospital. And before I get to my questions, on the last slide there was a URL.
Mm-hmm.
Can you just put that up again so we can write it down? Or maybe send it to us.
One moment, I'm going to put it in the chat myself.
Okay, thank you, Guy. That's great. So my first question is, do you want to be a teaching hospital? Because isn't that where the money is these days? Isn't that the best way to get and then retain good staff? So is that an ambition that you have? And would that go hand in hand with redevelopment of the hospital?
I'm going to let Nikki answer that. I think the answer is a resounding yes, but I will hand over to Nikki.
Thank you. It's a really good question. We already have quite strong alliances with University of Reading, and our first 2 University Department of awards were made last year to 2 specialties who've achieved excellence in terms of teaching and research and the standards that the university sets for them. So absolutely, we're really keen. We already host medical students from the deanery on their placement and their rotations, and we are absolutely looking to the future based on predictions for how many additional doctors will be required and the growth in medical school places required to embark on, well, we already are embarked on that journey to work with the University of Reading to create a medical school. As you can imagine, these things take a long time in the planning and the delivery. But the model is proven, and in terms of getting new medical schools up and running around the country, we've seen, for example, I'm not sure if you're familiar with Birmingham, but Aston has recently established a new medical school, and the way to fast track it is work jointly with an existing medical school, so that you're not reinventing the wheel when you set up. And we certainly, through our Chief Medical Officer and other colleagues within our organisations, are absolutely pursuing that as a route forward for all the reasons you quote, and certainly when we recruit staff, one of the things that attracts them is research and the ability to get involved in teaching to broaden their professional scope.
So we are very ambitious. Yeah.
We're ambitious and we're realistic, and I think we're absolutely perfectly placed with our already strong ties with the University of Reading, and those will only get stronger over time. And yes, we're both very keen on the development of a medical school.
It would be very good for the university as well, wouldn't it?
Of course.
It would be great for them. So you put up four scenarios: refurbishment with some building on the existing site, and the other three. Have you any idea yet, or is it too early, how much that might, either of those scenarios might cost? And
yes.
if you choose, or if, I don't know how the decision will be made, whether it's going to be made by the hospital or whether it is a local decision with hopefully lots of residents saying what they want. But if you choose the last one, a new hospital on a greenfield or a brownfield site, you got any thoughts about where that might be?
So I'll come back to the first question. As Victoria explained, the process to go through to secure Treasury funding for a new hospital is quite lengthy. Alok Sharma is working with us to try and help condense that process. But as it stands at the moment, the first stage is the one which we're working on at the moment, which is the strategic outline case, which sets out, and at this stage you have to consider all options. You're not allowed to submit a unilateral view and one option only. The Treasury will require us to submit the whole range from very minor refurbishment up to full new build somewhere else, and that's common for all of the hospital schemes that are in progress at the moment. The SOC does many things, one of which really is to flush out the amount of funding that is available, because clearly the scenarios, as you've seen set out, have hugely different indicative cost outlines for them. The team at the hospital I'm working with Victoria at the moment, we are just working through those. We're going to submit the SOC in late autumn, and we're just working through now on a sort of, you can imagine, construction cost per square metre and indicative costings at this stage. We're not at the detailed drawing stage of individual rooms and individual departments. That would be much more progressed at the next stage. But what we have asked our master planners to work up, and those are the options we've come up with, are it's all to serve our clinical strategy. So the estate strategy is really important, but the most important thing is our clinical strategy, and you know, the built environment that we need to operate the clinical strategy and the services that we know are coming and we believe will be developing in the way forward. We're creating the built environment to support the clinical strategy. So that's been a real driver of this. In terms of the costing, they're rather like telephone numbers at the moment, as you can probably imagine. Lots of zeros. But we will, through the SOC process, get a very clear indication from the Treasury as to the options that they would consider affordable within the funding envelope we have. The indicative sums, when we first were made aware that we were on the HIP2 programme, was a £200 million build. We're very hopeful that the actual amounts will be a number considerably north of that. It wouldn't be less than that, but at this stage we haven't yet got confirmation of exactly what that sum would be. So the SOC will flush that information out in terms of the response we get from the Treasury. And in terms of sites, we obviously at this stage, because we're not able to say we're going ahead with a particular operation or not. At this stage, we haven't got any fixed view of what sites that might be. We're keeping, again, as Victoria said, keeping all options open and on the lookout for suitable sites that might fit the bill. Again, it's very dependent, as you can probably imagine, on planning. So the massing of buildings, if you look at places like UCLH in London on Euston Road, they've built up, and so the footprint they require for their build was significantly less than we currently have, because ours is a lower massing and a lower number of stories on individual buildings. So the eventual redevelopment will depend on any option we pick. Actually, will have to be done in close conjunction with the planners for the site we choose to develop, so that we're in compliance with planning regulations as regards massing and height of buildings.
Yeah, I'm sure there's lots of good reasons for staying where you are and redeveloping where you are, and there's also lots of good reasons for moving out and going on to a nice brand new site where you could attach the teaching hospital and all that sort of stuff. So there's an awful lot for you to consider over a few months. Good luck.
Thank you.
Thank you, Clive. Jim Fruin, please.
Technology catch up. I need to apologise as well. I should have declared interest. I have a family member that works at the hospital, and also as a community first responder. I end up sending you quite a few people through the doors anyway. So a dual interest there. Firstly, can you pass on my thanks, and I'm sure the thanks to the committee, for all the work that's been going on throughout this last few months. I know from the stories I hear and from my involvement how hard it must have been for you. So thank you to everyone at the RVH and the rest of the NHS.
Thank you. I'll certainly pass that on. It's a huge team effort, as you can imagine, both within the organisation and without. So no, it's been an exceptional period. But thank you very much. I will pass that on to colleagues. Thank you. It was a pleasure to hone some of my cooking skills and send vegetable curries and things there during the first parts of it. The current site, you're right that the building is in disrepair. But also from a location perspective, parking, particularly for staff as well as for patients, must be a big issue. And if you extend the current site much further, that will only exacerbate, that will only get worse. It is an ideal location for public transport. It's not a good location for transport for people that have no choice. My question really is that there is a large amount of organic growth in the community at the moment. Reading and the surrounding areas is growing, and it's likely, with the potential changes to the planning rules, to grow very, very quickly over the next 10 years. You're talking potentially in excess of 30,000, 35,000 new residents in the area, just in Wokingham alone. What are the timescales of getting to having a operational building? Because if it's beyond the 10 years and it's throughout that 10 years not coping with the organic growth, we're just going to be in more and more stress and more problems. It's a really good question, and you know, this area is absolutely one where we're projecting significant growth in both patients and families and traffic, etc. So I think there are two angles to the answer I'll give. The first is we are actively engaging with everyone who uses our sites, all 6 of our sites, as to how we can reduce the impact on the environment and provide alternatives. So you'll be aware through COVID, we flipped a load of outpatient appointments to virtual, non-face-to-face, and we moved a lot of activity off the main Reading site to our other sites, so that we were able to dilute the volume of visitors coming to the RBH site in Reading. We're also working with our staff, because many of the journeys that are made and many of the cars that are brought near the site are our own staff transport, and we're actively engaging with staff looking at how we can increase. We offer staff the ability to buy bikes through the payroll deduction scheme, and we're encouraging our staff through we're refreshing our shower blocks and changing facilities on site to encourage as many staff as possible, because many live within walking distance of the site, huge numbers, and we're trying to nudge that behaviour change for those who are able to access the site other than by private car. As you've mentioned, a number of our patients and folks who need to access our services have no choice. They're not able to access public transport. And one of the tenets of the design, whether it's staying on the existing site or going to a new site, is how do we make sure the site flows properly, so it's possible to drive in and drop off and go and park somewhere else, or shuttle buses, park and rides, etc. That would mean that we're not trying to bring ambulances and staff vehicles and delivery trucks and the blood sample van from the pathology labs and the waste trucks all through the same small stretch of road, because the site does get incredibly congested, as you've observed at times. We're also trying to, through technology, nudge behaviours as well. So you may have seen our Ask A&E promotion, which is encouraging folks, instead of turning up at A&E, to log on and use an app to help triage what it is they may have wrong with them, and therefore find a more appropriate help than coming onto site to A&E. And we're certainly also working with our logistics suppliers to make sure that our deliveries are coordinated in a way that reduces traffic impact during peak hours. So what time they deliver to site, so that it's not in the middle of the morning rush hour. So we're doing huge numbers of things to try and reduce the impact, and working, over the COVID period with the council, we were very pleased that the university and both Reading Council made a number of car spaces available, hundreds of car spaces available for us, both in the Queen's Road car park, on the streets of Reading, and up at White Knights campus, which meant a lot of staff were able to literally do a park and ride or a park and walk. And we're looking to see what we can do to continue those where possible, even if it's not at the same scale that we had during the pandemic. We're absolutely addressing this with vigour, and I'll perhaps bring Victoria in terms of the comms we're doing with our staff and our stakeholders to find out, not just on the site redevelopment, but what else we can do to assist in traffic and travel and transport, because it isn't just about parking. The deliveries we have, you can imagine, for a 450 million turnover business, we have huge numbers of physical deliveries as well as huge numbers of staff, 5,500 staff and volunteers across our sites. So we've got a lot of work still to do, and this consultation on the site redevelopment asks about, are the things we haven't yet thought of that we should be doing to help flow better, the logistics of those people and those things arriving and leaving our site. Victoria, do you want to just pick up what we're doing in terms of the traffic and transport, travel and transport stuff?
Yes, thanks, Nikki. So always controversial when you're looking to reorganise or change anything that's traditionally been provided or supplied in one particular way. But one of the things that COVID has shown us as well is that actually people are keener to walk where they came, or to park and ride, or to come by bicycle. So what we're doing is a whole, not a statutory consultation, but an informal consultation with staff to work out who the staff are that absolutely need to bring a vehicle onto site. And often it's those who are the very frontline staff who have to take over a ward of patients, or to do clinics, or need to go off-site during the day to one of our other sites and come back again. But there are many other members of staff, like myself, like a lot of the executive, who don't need to bring a vehicle onto site. They can use public transport or they can walk or whatever. So we're doing this whole piece of work at the moment, which is going to take a good couple of months to work out who's coming in from, you know, all four corners of Reading into the organisation, and what we can do to make things easier for people, but also to improve our environment and be part of the sustainability agenda as well. So we're nowhere near finished yet. There's a lot of conversations to have, but we're on that journey.
One of the particular issues you have as a business, if that's the right word to use, is the fact that you're 24 hours a day. Yeah. So park and rides is okay during daylight hours. At 2 o'clock in the morning, I wouldn't walk up and down to the university. You're
absolutely right, Jim. And for those people that are there, in the sort of out of hours, most definitely wouldn't be sensible at all to be advising or recommending that they do anything other than, you know, bring in their own vehicle, travel with their own vehicle, or buddy up with someone else if that's the way to go, most definitely.
Thank you very much, ladies. And thanks to all the staff.
Thank you.
Thank you. Adrian, have you got a question?
Yeah, thank you very much for coming today. I really appreciate it. You know, I think, we've, you know, through actual experience of Royal Berks Hospital, you know, having an infection in my knee joint, which was, you know, the reason I've got 2 legs is thanks to the clinical care that I received at RBH. So thank you very much for that care. But it was clear that when I was in hospital, actually the buildings and surroundings were actually affecting the delivery of the nurses and the doctors. I mean, the nurses couldn't all fit in the corridor at one time because of the narrowness of the corridors, etc., etc. I would like to say that you know, this is a growing place. Jim has already mentioned this. You know, we're going to get more residents here, more elderly residents, and I think we should be really ambitious. I think if we do, you know, a small piece of a build or something, or a partial rebuild, I think you will still be, you know, having the issues of a site which is really quite compromised. I know there was, in 2012, there was a development by Dr. Philip Lee, who was the MP for Bracknell at that time, which was promoted by Dr. Philip Lee and Theresa May, who are both far more experienced than I am. And they were advocating that this is one of the few areas in the UK which really requires a major investment in hospital infrastructure. You know, and they were talking about a plan of having a major incident hospital. So they were saying at that time, those years ago, that you know, we are on the motorway network, the M25, the M3, the M4, Heathrow, major rail links, but we do not have a major incident hospital. And it would make sense for somewhere in Reading or close to Reading, or perhaps close to the M4 or something, to be not only, as Clive mentioned earlier, a teaching hospital, but also a major incident hospital. So really, my question is, would you wish to be going for that kind of status as well? And, you know, how ambitious are you?
It's a really, really good question. You'll probably be aware at the moment, major traumas either go up north to Oxford, or east to London, or south to Southampton. Those are the nearest regional trauma centres. I think it's fair to say we're trying to be really ambitious, and we're trying to secure the maximum funding that we possibly can to be as ambitious as we can. The timescales for this, as you're probably aware, is not going to be next year. We will probably get the outline business case and then full business case submitted within probably 2 years from now. And then the designing, the building, the planning, and all of the detailed work that goes into that, we're probably talking about between 8 and 10 years from now that the the plans in fullness would come to fruition. Obviously, it depends on what scale of affordability we have as to how big that development would be, but we're certainly working with Alok Sharma, who's very keen through his department to speed things up and get shovel-ready schemes to help boost the economy in terms of economic regrowth as well. We are also looking at the projections for population. So you'll see when you access the microsite, which I do hope colleagues will take the opportunity to do, we're asking really open questions from colleagues around what do you think? So should we, for example, some of the things are, should we go for a hot and a cold site? So have one part that's able to do elective work and planned orderly work, and another site that is absolutely wrapped around emergencies and unplanned care, diagnostics, urgent care provision. We've been actively looking for additional monies in the meantime. So we were delighted a couple of weeks ago to hear that we'd secured another £4.5 million to help enlarge our existing ED. So we're going to be creating extra cubicles for both majors and paediatrics, as well as a larger waiting room before December, which will really help the flow now today. And Victoria mentioned the seed funding. We bid to get early drawdown of funds from the HIP2 scheme, and we've secured funding so that we can de-steam our site. So that will be removing 3 miles of pipework from the site and moving over to a green boiler by the end of the financial year, so by the end of March 2021, which will make immediate improvements to the heating, and all of the buildings will have reliable central heating, which sounds very simple, but actually it's really fundamental to make sure the temperature is correct in every building, which we've not been able to assure before now. So in terms of the major trauma centre, again, population growth and demographics, we are asking for input from the commissioners, both local commissioners and regional and national NHS England colleagues, as to what services are going to be required, because obviously there's national modelling going on of population shift. Some areas are losing population and actually probably have too much infrastructure for what will be in place in 10 years' time. And other areas like this area are absolutely predicting large growth. So the shifting sands of where you need to put your major infrastructure to serve those populations as populations move around is really important part of future planning. And so that's why we're engaging with our regional and national colleagues through this engagement process to influence and hopefully shape a very ambitious future.
And I think it's great that you're trying to involve so many different parties in this, but I always caution. I work in the IT industry, and a lot of actual major change is when the end consumer is completely ignored, actually. And Henry Ford said focus groups don't give you anything, because when he asked farmers what they wanted, they said a faster horse, not a car. But it's really important that we get that strategic view, and I think I'm seeing that from you, and that's very encouraging. One of the things that has been talked about in numerous meetings, certainly in this HOSC, is the sort of bringing together or potential bringing together of different CCGs. There's also technology sharing across Berkshire, Oxford, and Bucks, Bob, as it's called. Is this going to be part of the plan, or is this affecting you, or are there any considerations there?
Again, another really, really good question, Adrian. We actually last week we welcomed Dr. James Kent, who's the lead officer for the BOB ICS, the Buckinghamshire, Oxfordshire and Berkshire ICS integrated care system, which effectively covers the areas previously covered by Berkshire West and Buckinghamshire and Oxfordshire CCGs. He is the accountable officer for the patch, and he's currently undertaking a review of what structure he would like to put in place, again in consultation with colleagues like ourselves and other stakeholders, as to what commissioning arrangements he needs to have at place level and at ICS level for the services that are required. So it's very timely, and that structure is undergoing review at the moment. It's interesting as well, we're also working really closely with our primary care networks. So colleagues, myself and other colleagues have been meeting regularly with our GP colleagues and continuing to do so, because again, through COVID, I don't know whether any of you were aware, we developed a new pathway at the hospital called TIC19, which brought together the diagnosis, early diagnosis, and created virtual wards of patients who had suspected COVID. GPs were able to issue patients with pulsometers, oxygen pulsometers for their fingers, and we phoned patients every day to see whether they were okay or whether they needed to come in. And these boundaries between the commissioning organisations, the primary care GP colleagues, and ourselves in acute, and also our colleagues at the Community Trust as well, have really blurred through COVID, and in a good way, because the services we're looking at to develop for the future are much more boundary transparent. In other words, they're focused around the patient, and if we need to move things from one place to another, we will do, so that the patient isn't affected by lots of handoffs between different organisations. And certainly that's the intent with the commissioning landscape moving forward. What can we commission regionally? What makes sense to consolidate at place, and what makes sense to look at a broader area? So, for example, hefty kit like CT scanners, MRI scanners, traditionally each hospital would have said, well, we need one of those, two of those, one of those. We're looking at how can we much more efficiently site that diagnostic equipment in places where there's large populations and therefore access, which may not be where we'd have traditionally put one, but it makes sense because we can absolutely max them and run them 24/7 and make sure that no patient has to wait for too long for their diagnostics. So I really welcome the developments with Bob ICS, and certainly when James Kent was with us, he spent the day with us last Tuesday. I'm really impressed by his vision and his focus on what's best for patients and making sure the service is aligned to that.
Again, thank you very much for the answers.
Thank you.
Thank you for that. Guy Granderson.
Thank you, Chair. Most of my questions have already been covered, as always happens in these sorts of things. Again, I want to look around the new hospital on the Brownfield site aspect, because I think it's very good that you're doing it. Personally, if we had unlimited funding, it would be very much my preferred option. Effectively put something, let's say, on the Green Park in Reading, close to where they're building the new railway station. That sort of location immediately springs to my mind for good transport links, good location in terms of its green space and everything. Because having been into the Royal Berkshire quite a few times, its location can be somewhat grim. And it reminds me very much of the old St Mary's Hospital down in Portsmouth, in the middle of the industrial estate, in the middle of the housing estate, etc. And then you compare that to the hospital which replaced it, Queen Alexandra, which is basically set into the side of Portsdown Hill in the countryside. So my question is much more around, what do you foresee any challenges if we do get a new hospital built in the county, for the lack of a better description? The challenges of basically spinning a potential hospital up whilst maintaining existing services on the old site.
Guy, that's a really good question. I mean, paradoxically, it's actually much easier to build a brand new hospital because you build it all and then on moving day you move in. So I was in Birmingham at the time when Selly Oak Hospital and the Queen Elizabeth Hospital in Birmingham, the brand new University Hospitals Birmingham big build, which is one of the biggest hospitals in Europe, that was built as a brand new build on a green site, and there was a big, July 2010, everyone moved in. So that was very straightforward, actually, because you're vacating one place and moving into a brand, rather like if you if you compare it for your own home, it's much easier to sell up and move into a brand new house because you just shift everything and move in than having builders and canopies and tarpaulins and rooms out of use and the water's not on. And I mean, I exaggerate for effect, obviously, but it's much more straightforward to do that, have a brand new build and just move into it. Clearly there are huge cost implications of building everything new, because again, if you're familiar with our own site, you'll know that many of the buildings are post mid 1990s, so many of the buildings are actually in very good condition and are okay. We have some examples. So for example, West Drive, which we've just moved out of, and we're going to be demolishing that by the end of the year. That was 1947 Nissan huts, so those will be demolished by the end of March. But the options that we're looking at, and certainly the collective energy of all of those who've been involved in the master planning, it was relatively straightforward to set out a number of options. The difficult thing is, okay, so how would we phase that? So if we're going to do a substantial rebuild on the existing site, which bit do you knock down first, and where do you create a decant building, and who moves out when, and then to try and avoid triple and quadruple moves before you eventually arrive in the right piece of built environment that you're going to end up in. So there's a lot of complexity in terms of redesigning, knocking down, rebuilding, decanting on the existing footprint. We have got the ability to do that because, again, if you're familiar with the site layout, we will have space where West Drive would be demolished, and we will have space at the end of the South Block annex, so the opposite end of the site to the North Block facade, right up near the university end of the site.
Where the car park is at the moment.
Yeah, where the South Block annex car park is. So that land also provides an opportunity to create decant space. And similarly, we're constantly looking at what activity could we temporarily relocate. So during COVID, for example, we relocated the majority of our elective surgery to the 3 independent hospitals in Reading, and we decanted a huge amount of outpatient activity out to West Berkshire Community Hospital, Brantsbridge in Bracknell, and also out to Townlands Hospital in Henley-on-Thames, because we were trying to keep the hot COVID site hot and move any cold activity to the other sites that we had. So depending on the money, and I hate to keep coming back to money, but as you know, in life, everything's around a budget at some point. Depending on the funding envelope we're able to secure, and we will be looking at attempting to secure funding other than just Treasury funding. So we will be trying to find if there are other partners who wish to come in with us who would be interested in co-funding. So we would, we may be able to access funds from other sources as well as the Treasury, and certainly that's what other hospitals who are also in this wave of hospital funding are also looking at doing. So we've got to explore all of the options, and all of them will have to be thoroughly worked through in terms of deliverability, because rather like the M4, we have to keep it running. We can't just close for 2 years while we do some building work. So all of the services, the obligation on us as leaders of a hospital is we have to keep all the services running all the time, even though we're redeveloping.
That makes complete sense to me, as someone whose mother worked in the NHS, and I was basically wandering around QA in St Mary's during the rebuild and decommissioning service whenever I was basically having to go find my mother, for example. I know how disruptive it can be, and it's an absolute nightmare. The one recollection I recall from QA is what was a 30-pace walk became about a quarter of a mile round trip around the building, which was rather interesting and not very conducive to anyone in a wheelchair, that's for certain. One aspect, the additional funding line was what struck me there. I presume that we're not going to... has PPI funding been excluded, included? Because I know that some of the contracts from when they were set up in the 90s, the late 90s, were particularly unpleasant in their terms, as it were. Is that something that has been fully weighed up?
The PFI model, I think at the time when the
PFI, not PPI.
Yeah, so the PFI model was one that at the time when it was to keep debt off the balance sheet, really. So, and then international financial reporting standards came in and all the PFIs were back on the balance sheet. But certainly one of the trusts I used to work with had a PFI that was 12.5% loan debt, which is, you know, against a climate of the current interest rates is looks hugely expensive. We wouldn't be looking to go down a hugely expensive loan finance route. We're looking at as options what other routes are there. So, for example, again, and these are not restricted. This isn't everything we're looking at, but for example, joint ventures with other organisations. If you look in London, again, I think of Guy's and Tommy's as an example. You look at who else might occupy the space. So if Guy's and Tommy's are looking at building a large tower block next to the Shard in London, they're looking to co-occupy that with a major healthcare pharmaceutical company, so that they would share effectively the running costs of that building, because they will occupy some floors and the company will occupy other floors. So it's all about, again, looking at who the stakeholders are and who would make sense to co-locate with. Because different partners might bring different things to the table in terms of funding opportunities. So we're looking at lots of options around that.
Okay, that's good. One final question then from me, and that's basically in terms of support from councillors here and Woking Borough Council as a whole, what do you want from us?
Victoria, would you like to answer that one?
I thought that would be a tricky one.
Yeah, so and that's a loaded question, guys, isn't it? Because what are you prepared to give? But hey, we're not after your money, but what we are after is kind of your support as a key stakeholder and partner with us in our plans to go forward with the SOC. So, you know, I know others have sort of written letters of support to go into the Treasury and the Department of Health to sort of support what we're trying to do. And additionally, it is, you know, you've come up in the last sort of 5 minutes with lots of ideas and views and opinions, and very informed they are too, not least because you've got, you know, experience of someone who's worked in the NHS, but also as a user of services, etc. So anything that you can contribute through our microsite in terms of, you know, your views and opinions, that would be really helpful too. But as I say, as a HOSC, if you were prepared to do a letter of support for us to go forward with the SOC, that would be fantastic. But that is entirely, you know, we're not holding you hostage on that. That is entirely your decision. But we hope that we've convinced you with the, you know, with the case that we've brought this evening.
Thank you very much for that, Victoria. That's great. And Ken, can I propose that we do write a letter of support? Because I think the hospital site needs redevelopment, whether that be new or proper redevelopment. It is fraying at the edges in some areas.
It is.
I think we might be able to do a bit more than that as well. The right places.
I'll second the proposal.
Thank you.
We'll get all members, if you could actually go to the microsite, have a think about this by all means first. Go to the microsite, and I think we should all do the questionnaire, which will probably help as well, I think.
I agree. Anyway, that's it from me. Thanks, Ken.
Okay. Rachel, next, please. Thank you.
Thank you very much. My question is similar to the questions that Adrian and Jim were asking, but I guess with a slightly different slant, in that it is a very difficult site to access, and it must be very hard for people with an emergency to get to that site at rush hour, for example. To what extent are you able to push a case that you need a site which is easily accessible by public transport and by green transport?
That's a really good question, Rachel. And I guess if I can just pick up the accessibility first. So we've engaged a company called Accessible to help us with, once you've arrived at site, making sure that all our entrances and our signage and our steps and our ramps are as well lit and accessible as possible. So we're having a full review of all of our sites and all of our entrances and all of the wayfinding around all of our facilities before we do any site redevelopment, just to make sure that that's as good as it possibly can be once you've arrived at our front door, as it were, including finding your way from the pavement or from the road that we're on. So they're doing a full literally walk through everywhere to make sure drop curbs are in the right place, signage is okay, lighting is all right, and to make sure bus stops are in the right place again, so that you can reach where you need to get to from whatever route you use to reach us. Certainly the council, Reading Borough Council and ourselves, we've been in a number of discussions around we talked about it earlier, our traffic and transport impact, and certainly we have the I don't know whether it's notoriety or what, but we are able to completely clog up the centre of Reading on occasion. Not that we would wish to do that, but we know that that's been the case, which is obviously as an anchor institution and a good corporate citizen, that's not what we would be wanting to do. And also, I mean, I've been increasingly talking to patients about their experience of our services, and one of the things, I guess one of the benefits of COVID has been the way in which we are able to spread out the number of appointments that we offer and the arrival times for folks, because again, if I look back a year ago, we would see great surges of traffic arriving just between 8:30 and 9 in the morning for morning clinics, and another surge between 1:30 and 2 o'clock for afternoon clinics. We've certainly found since lockdown and since we've begun reopening our services again that because of the way we're doing many virtual clinics, that's reduced the traffic onto site considerably. And also because we're encouraging patients to arrive in time for their appointment, but not too early, we're seeing less traffic in these great bulges of traffic flow arriving soon. In terms of Reading rush hour traffic, I know that blue lights can get through because they put their lights on and they whiz through. Obviously, private citizens in private cars aren't availed of that facility. But we are talking all the time to colleagues at the council about the routes, the blue light, we call them blue light routes. There are particular routes designated, as you'll know, that always get gritted in the winter and are priority routes for ambulances and first responders to access our sites. So we're continuing those ongoing discussions, and again, through the microsite and through your feedback to us, if there are specific questions around particular times of day or particular access routes that you feel we should be aware of, again, it will really help our design and layout plans for what we might site where. So one of the plans we're looking at is, do we create a separate A&E entrance on Redlands Road, so that would literally be a loop-the-loop round for ambulances and drop-offs, or make Craven Road the A&E main entrance or whatever. So we'd be really keen to get your thoughts as to how we might best do that. Were we to stay on the site? If we aren't staying on the site, obviously a blank piece of paper means we could practically do anything, but we're actively investigating all of those options on all of the possibilities. But your feedback and particularly be as specific as you possibly can about, have you thought about this, what about this, and this might be a solution. That will really help us.
Fantastic, thank you very much. I think I had as well a thought about if you do fulfil your ambition to become a major incident centre, if there is a major incident, it's much more likely to happen at a peak rush hour time, and how suitable the site may be for that if you're going to have multiple ambulances trying to reach that site.
In terms of major incident response, regardless of new build or new development, we've got very, very well rehearsed protocols within the NHS, which involve local resilience forums, as I'm sure colleagues are probably aware. And in the event of a significant major incident, which I think you're alluding to, we would, in collaboration with police colleagues, and we would have roads closed and be able to rush vehicles through and have full access and could close roads, etc. So access to anywhere, regardless of a development or not a redevelopment, if something happens tomorrow, through emergency powers and major incident response, we would be very confident. Just as you'll see on occasion, we have the helicopter land on Reading Boys School Field. And certainly if we needed to, we can get all access routes sequestered for major incident response, which would mean we could bring the required number of vehicles or people to us expedited as quickly as possible, because every moment can be important in terms of life-saving actions.
Okay, thank you very much, and I'm really pleased to see that this is under consideration, and it is such an ambitious plan.
Yeah, thanks. And just to reassure, I mean, if anyone has a cardiac emergency at the moment, they are literally driven straight to the back door of the cath lab and unloaded from the ambulance directly into the cardiology department. Same with, as I say, with the ED. If any patients need urgent blue light transmission, they are whisked through to the majors as soon as they need to. So I say that's already in place. We're not waiting for the redevelopment to be able to see urgent patients urgently.
Super, thank you.
Thank you, Rachel. Abdul, you're next.
Thank you, Chairman. Nikki, my question is regarding population and also, if I see my note, because a lot of answers you already be given. In terms of stakeholders, how many local authorities going to be your service user? That's one. And secondly, in terms of this super hospital, which I'm very happy to see that all the local MPs are very much working with you. In 10 years' time, isn't it very difficult to anticipate what sort of population you will be serving in terms of growth?
So a really good question. Getting great questions this evening. So in terms of population, so there are data banks we use, and Victoria can probably comment more on this, but we access all of the civic planning databases around population growth. Most local authorities, as you know, have development plans which indicate the number of new homes that they're going to be bringing on stream over the coming period, and depending on the end date of those plans, obviously they're looking 5, 10, 15, 20 years forward sometimes, and almost designating whether there are new towns or new suburbs being originated. So we're working closely with all of the stakeholders for whom patients we treat, those areas that people live in, and we have very forensic demographic information about all of our patients. So we know which GP practices our patients come from, we know the home addresses of all of our patients, and therefore we know where patients are coming from today. And as we've alluded to during the conversation this evening, depending on what happens in terms of major service reconfiguration. So, for example, if we are successful in winning additional specialist services to come to Reading over and above the ones we currently provide, we're obviously a very large district general hospital, but we also provide what are deemed specialist services, so things like bariatrics and some spinal work. Then the more of those we grow, then the larger the population area we cover. They're organised depending on critical mass. So if it's quite a rare condition, then there would be perhaps one big trust like Oxford would serve a huge area because there aren't very many patients in that regard. So all of the local authorities that we currently see patients from, we would consider to be our stakeholders, and we're contacting them as part of this consultation. Victoria, I don't know if you want to run off the list, but I mean, it's everywhere you can imagine that is within travelling distance of us would be an authority that is involved.
Yeah, that's absolutely right, Nikki, and also Abdul. So you know, we use things such as the ONS data, but the JSNA, also population health management now, which gives us a lot of really rich information about not just those patients once they become ill and come into us, but the prevention agenda too. So working right across the local authorities with our health and wellbeing partners, a joint health and wellbeing strategy that feeds into that as well. So you're absolutely right. The population is growing, and we're trying with all the information, all the data that we have to stay ahead of that, so that we can absolutely meet the needs of people, whether that's, you know, pre coming into hospital, in their hospital period, and post hospital too, and working with our primary care colleagues in the primary care networks. So that's been the real beauty of working as a system in the last couple of years. That's really been an advantage for us and for our patients and communities too.
Thank you. It's been so nice to hear lots of things from you too. Excellent work. Thank you.
Thank you.
Thanks, Abba. Jim, Jim Free.
Thank you, Ken. You've mentioned a few things about COVID, where we looked at how we approach things and how we can speed things up. Can I ask that we apply the same mindset to this initiative about the new hospital or upgrading the hospital? Because 8 to 10 years seems an horrendous amount of time. And can I also ask that as a committee, when we do write our letter of support, that we include trying to increase the timescales of this? 8 to 10 years, we will have the additional 30,000 residents in the area, plus and maybe more, and the hospital will be under severe stress, so we have to try to speed it up. And I think COVID has taught us that that can be done. Right or wrong, we managed to produce a number of Nightingale hospitals, whether they were the right thing or the wrong thing, in some very, very quick times. That sort of urgency we need to apply to this as well.
Jim, I agree. I mean, we're as a leadership team at the hospital, we're champing at the bit to get going on redevelopment, as you can probably imagine, and I think it'll be really symbolic actually when we get the wrecking ball and demolish West Drive in the next couple of months, because that will really send a signal out to our stakeholders, our staff, our patients, and all the other parties who have a really strong interest in what we're doing, that we're serious about redeveloping the site. We are actively lobbying, as you would probably imagine, colleagues at the Treasury, Department of Health, and through our MPs to get this process sped up. And we know from a number of other organisations around the country about the length of time it can take from the initial granting of here's an option to apply to the new door opening and the ribbon being cut, can seem a remarkably long time. So we'd be so glad of your support in that regard, and it's absolutely the way the leadership team at the hospital is thinking. I mean, I would love to get months and years shaved off the application and approval process, not only because, I mean, we've seen recently, you may have seen our announcement last week, we are setting up a lighthouse laboratory which will provide testing facilities for the community at our Bracknell Brantesbridge premises, and that, you know, we see ourselves as an anchor institution not only providing healthcare that is needed by the population, but also as a major stimulus of economic growth. We'll be creating over 300 jobs at Brantesbridge, but we need to get up and running by December, so it'll give a massive economic boost not only to the building firms who are doing the fit out working 24/7, but to the staff who will be able to join us and work those 3 shift patterns to help us to run the lab 24/7, and the hospital build, whether it's a redevelopment of our Craven Road site and or whether it's a development at a different site. You know, we're talking hundreds and hundreds and hundreds of jobs that will be created, and just the demolition of West Drive and the de-steaming of the site over the next 6 months is going to create several hundred construction jobs on our Reading site. So we're very aware of our ability, if you will, to kickstart, and we're going to be requiring all of the contractors who work with us a commitment to take on and train and support development of apprentices. So we're skilling up school leavers and other young people who may have very limited work opportunities to join the workforce and gain valuable skills for future employment opportunities.
I will certainly push for those words or words of those minds to be put in can if we can.
Thank you.
No problem.
Clive. Now, Clive, what have I told you? How many times now? Second round questioning.
Just one very quick question. When does this consultation end?
Victoria, would you like to answer that one?
So the exact date is out of my head. The SOC is going in the autumn, Clive, which is early October. So the first stage of the consultation in terms of getting us to SOC is almost imminent, but then we've got so much more work to do after that. So we are looking for, you know, a period of, as Nikki says, up to 8-10 years to make sure that we can refine our plans and to get it into the shape that you know, as I said earlier, building up from, you know, from the ground up, metaphorically and physically. So you've got a lot of work to do yet, sir. And if you're coming on to be one of our governors too, you're going to have even more work.
Okay, thank you very much.
Thank you, Clive. What can I say? Thank you very much. That was a very interesting presentation. Now, I'm guessing that the microsite questionnaire for October, that really just needs to show our support for your options, really. And as you say, after that, when you know which direction you're going in, then it's probably more relevant for the smaller details or the smaller considerations. So
yeah, that's right.
Ken, thank you.
Yeah.
Okay, we'll
but
try and get
also
that
to challenge some of the thinking as well at this stage, because that will help us to refine our thinking.
Yeah, absolutely. I mean, as you can see, there's quite a lot of bright people on this meeting. They've got some good ideas out there. So if we can get those into the site, hopefully you may find it helpful.
Yes, please.
Well, in that case, can I just thank you for giving up your time for this? It's been very appreciated. And can I say that we might look forward to seeing you again? So keep in touch.
Ken, we would be delighted to come back, and so I'd just really like to thank you again for extending an invitation for us to join you and the committee this evening. You are absolutely key stakeholders, and as we've seen this evening, huge amount of knowledge and interest and expertise around the table, which we would be really glad to have with us on this journey to help us make sure we make the best possible range of options and solutions for the public we serve. So thank you once again. It's been a real pleasure to join you, and please let us know when you'd like us to come back, and we'd be delighted to.
Nikki, thank you very much.
Thank you so much.
Thank you.
Thank you.
Thank you.
Right, that's the Vice President. All right, now we get to the, I think this was Nick Durham now. Durman, is it? Nick Durman. Nick, would you like to go through the Health Watch update at all, or would you like us just to take it as seen? Are there any comments you'd like to make?
It depends how long you want to sit there, I think.
No, we're always here for you. Yeah, we got the report. I think everyone got the copy of the report that you produced here. And it was interesting. I wasn't quite sure. The only question I'd have had about it was how much extra work did COVID give you once it all started hitting the fan, so to speak? Did you find your call rates went up a lot, or was it business as usual, really?
No, it certainly wasn't business as usual. Like a lot of organisations, we had to change the way we worked, because there's several ways people can share their experiences with us. One is via the website, one is to our help desk. That didn't change. The help desk remained open, the core hours. But of course, the other way was the face-to-face engagement. And of course, that had to stop. So our role really changed, and it primarily came down to the help desk providing signposting information, and for Healthwatch particularly to talk to our voluntary and community sector partners, particularly those supporting vulnerable people. So as an example, we would join in with the CLASP Adult Learning Disability Group twice weekly Zoom meetings with the sole intention of picking up any health or social care issues. And it won't surprise you that we did pick up a lot of health and social care issues among the vulnerable groups. So they suffered issues with pharmacy at the beginning. We heard Kevin talk about those difficulties. So we had to go and resolve that. Issues with nomad packs being removed. And I have got some points on what he was saying, but there probably isn't enough time, and I can follow it up next week. So our workload definitely went up. Our website, we made sure that we were providing good information on the website, because one of the comments we had back from many people was that they had trouble finding, and I think it says that, it does say that in the report, they were having problems finding accurate, timely, easy to find information, whether that's what is the current situation at the Royal Berks Hospital in terms of visiting, in terms, everything to do with the Royal Berks Hospital. There were complaints that they couldn't find the right information on GP websites, that they couldn't find the right information on dental websites. So we made a point of finding that information out, and rather than trying to press these organisations to get their information right, although we let them know that we'd heard these comments, we put the information on our website. And the number of hits we've had on our website, it's gone up 25, 30, 40% in some weeks, just for people hunting for the right information. So that's how it changed. It gives you a flavour of how it changed for us.
Yeah.
The key issues we were hearing about, and I mentioned it on the report, was around finding an NHS dentist. So that's been a big problem. People calling around not being able to get a dentist. And I think the clear thing to me around all of this is, in our communities, we have those people who are disadvantaged, and what COVID has done, and some of the lack of information, has made them more disadvantaged. Things like, I'll just pick up one example, the COVID restrictions presenting barriers for deaf people who need to sign and lip read. So if you're faced with a medical professional wearing a mask, and there hasn't been time to get a sign language, a signer in, and you don't have an advocate in any way, then how on earth are you going to know what they're saying to you when you would have had difficulty before? So that's an example of the type of issues that have been happening. I was going to make a couple of points, because you mentioned it was around vaccine.
Sorry, can I interrupt just a second? Sorry, I've been at work since 8:30 this morning, and I think this meeting's scheduled to be closed at 9.
Yeah.
I think there's a lot of really good topics to be discussed in the Health Watch.
Yeah.
And I wouldn't like to push this all into a short update without a reasonable Q&A session.
No, I'd rather come back and go through it, because I have made some points based on the speakers you've had this evening with additional information that you might find useful.
Yeah, I think we need to have further discussions around the pharmacy stuff, further discussions around the dentist stuff, and I would really appreciate your views on their comments. And when we get a lot of presenters come here, and obviously everybody always presents the good side, it's for you to check the not so good side. So it's very important, in my view, that we listen to you. So I would actually like this session to be rescheduled.
Perfectly happy to do that.
Sorry, if anyone can hear me, and I don't know if my microphone's working, the meeting doesn't have to finish until 10:30.
Yeah.
So we don't have to finish at 9, so you do have time to continue, should you wish to, tonight.
Thank you.
I'm personally exhausted. I would prefer another meeting scheduled, actually. But if everybody else wants to carry on, that's fine.
Well, I think what I would add is I've scribbled the notes down based on what some of the speakers have said. It would give me more time, if you had it another time, to formulate that properly and say, well, Kevin Barnes said this about pharmacy. And yes, he was very helpful when we had pharmacy issues, but there are these other issues that actually weren't resolved satisfactorily. As an example,
if it suits Nicholas for us to come back in a couple of weeks' time, I think I would be happy with that, because the more information he can give us, the better, because Health Watch are our eyes and ears throughout the borough.
Yeah, don't forget that Health Watch is at every meeting as well, and they religiously turn up at every meeting. So,
yeah, but our next meeting, Ken, is not for a couple of months, is it?
1 month, is it? Madeline,
In November, I believe.
Yes,
so it's almost 2 months. Yeah.
I've also started attending the CCG flu action group, and there's some stuff from that you might be interested in hearing. But it was only, I haven't had time to write up all the notes because it was only yesterday, so it would give me time to formulate that properly.
Yeah, because of COVID-19, that's very topical, isn't it?
I mean, what is everybody else's view? But for me, I'm completely done in now. I need a break. This has been 2 hours of intense Q&A around multiple topics. I think it would do a disservice to Health Watch to, not give Nicholas our full attention. And I've done 2 hours and a full day at work, and I can't take any more. Apologies.
All right. Now, what we'll do then is, not too sure best way around this. I think I'll have a chat with Madeline. We'll try and work out a time for whether we can do this. Nick, I don't know. Is it possible? I mean, normally we just go by what's in your report. So what you've actually managed to add in there is quite a few key pieces of information, I think, which would be very interesting. Do you think you could just give a interim report to us to start off, which Madeline could then circulate to members? And if then we could actually arrange another meeting if we feel that there's a lot of questions to be answered.
Yeah, I've got a lot of questions just from tonight's.
Yeah.
I'll send a supplementary report to the report you've just received, outlining the issues that I was going to raise this evening.
Yep. Okay.
And whatever date you arrange, that's fine. I can turn up as long as it's not the week beginning the 5th of October.
Fair enough. I'm away.
Yeah.
All right, Nick. We'll leave that there. Has anyone got any questions they wanted to ask about this particular report? Straight off, I see Jim, your hand's up, and also Rachel's. Jim, would you like to say anything?
Sorry, my hand was down. Sorry if it's not.
Oh, okay, Jim, no problem. Rachel, your hand's up. Is that left up or is that? No, I think that may have been up by accident as well. Okay.
No, sorry. Sorry. I was wanting to raise a slightly different issue. I can raise it now because it might link into what Health Watch do, or I can leave it until later. But I did want to mention it before we end this evening.
Well, I suppose I don't know whether it's relevant or not until you say it. So, yeah. If you want to...
Fantastic. Okay. So basically, the BMA last week they passed 2 motions addressing inequalities in healthcare. They were looking at 2 groups, the BAME community and transgender people. And actually, these are both issues that have been raised with me by residents. And I thought it would be great if we as a group could look at how we serve these groups within this area, particularly in light of the fact, if I look at BAME people, that's something like 16.5% of our population now in Woking Borough. There was one very specific thing which I thought that we could look at as well, which links with COVID and probably does lie outside of what Health Watch might be interested in, and that is vitamin D deficiency. So I will leave that until afterwards, but come back to that if we have a minute. Thanks.
I think, yes, we can look at a top level over that, what we do for that already. I think it's probably the Health and Wellbeing Board, though, that would be looking after that particular area, but we can certainly scrutinise whether they have done anything in that area. Madeline, do you want to have a think about that one, see how we can fit that into the agenda?
Yes, no problem.
Thank you. Clicked on the wrong button. There's no other hands up, so we can actually leave that there, Nick. Thank you very much, and we'll be back in touch with our views as well on how we proceed with that. We now have an item which after the comments we've just received, I'm going to suggest that we maybe just note for this particular meeting, because it is a very lengthy item, and that's agenda item 19 on dental services. Without anyone actually attending to go over this with it. I mean, the first few pages of that report, the letters, give you a good idea of what it's all about and where they're going, but without them here to answer questions, we could, if anyone has questions, again, we could send it to them and get a reply. But I think I'd like to get them in still to go over that report sometime.
Chairman, I don't know sorry to interrupt, Chairman. They have offered, if you do have questions, obviously they're not available today. If you send them to me, I can send them on to them, and they've said they're happy to provide written answer if that would be sufficient for members. I know Councillor Fruin's already sent me some.
I just feel that with the detail of that report, if they were here explaining the different parts of it, we'd probably have a lot more questions.
I couldn't agree more with you, Ken. Completely agree with your opinion.
I can't see you speaking.
Sorry, that was Adrian. Yes. Yeah. Sorry, I completely agree with you, Ken.
Sorry to interrupt, it's Nick here. Based on the feedback we've had from residents about the difficulty getting NHS dental appointments, about the lack of clarity on their websites, it would be good to have them here.
Okay, so I think because, well, there's two arguments here, whether dentists are very busy or they're not at the moment. They always sound as though they're busy, but I don't think that's something that they've generated. I think it's something the rules has generated. I was reading a bit about an hour fallow in between each customer and things like that. It must be a nightmare for dentists at the moment. So I'm on their side, but yeah, I think let's try and work that into a future meeting. But it all depends when they're free to come in and actually go through this report with us, I guess. Madeline, did they give you any idea of when they could be free?
I will follow up for you.
Okay, I don't want to put them out too much, but yeah, if we could just have the conversation with them and see how they feel about that.
Yeah, we don't want an agenda item which is like pulling teeth, do we?
Thanks for that.
Someone had to go there.
All right, so in that case, we'll note that report on this one. And of course, that does actually move us right along the list then, because all we're looking at now is the forward programme. Madeline, do you want to try that? Or...
Yes, certainly. So you'll see from the forward programme for November's meeting, we've currently got an update on Health and Wellbeing Board. From the discussions that we've had earlier in the meeting, I will obviously try and rearrange another meeting in between to look at the issues with Health Watch. Was there any other issues that members wanted to look at in terms of the November meeting? You'll remember previously the Management Committee referred.
Yeah, I think you've gone again. Jim, I'm going to assume that Madeline can hear you. Do you want to add anything?
You may want to look at that.
Oh, there we go.
Sorry, did I drop out?
Yeah, about a minute ago.
Oh, sorry. But I was just saying we had care homes previously, but we haven't had how we're working with our health partners on COVID. So you may want to look at that at some point.
Okay. How do the members feel about the COVID investigation? Is that wise to bring that in for the November meeting? I think that would probably fill that particular agenda meeting. And that leaves us then with January to maybe catch up. Let's find out from the dentistry first whether those people can come in. I think that will affect what goes in the next meeting. Are there any items which people would like to see on there?
Ken, could I just say that ONS management in October, I think, was going to be looking at the COVID review work that had been done by all 4 committees.
All right. Well, we've had 2 meetings so far, haven't we, with COVID type activities. And when's the management meeting looking at that?
Oh gosh,
some point in the middle of October. I can't remember the exact dates. Well, I don't know if I'll be around on the 18th of October, seeing as my second daughter is due around that week.
Okay, look, we've got well, this is a November meeting we're talking about anyway, so that won't affect what we're going.
Sorry, I meant November.
Oh, okay.
Oh, and also, Ken, may I just add that Children's Services in November, we have got CAMS on our agenda, and we will be inviting all members of HOSC to join that meeting if they wish to.
Yes, I'll certainly be on that one. Okay, any members? Well, the invite will go out from Madeline, I expect, to that particular meeting. So health overview and scrutiny forward programme for November. Is everyone happy with what they see there? I've got hands up actually. Rachel, are you waiting to speak?
Yes, I don't know whether this is the right committee to look at it, but it's the first one that I've sat in since this came up in the paper. But there was a very distressing article in the Wokingham paper this past week about a case dating back to 2015 and an elderly gentleman who'd ended up with a maggot-infested wound, and the police had decided there wasn't enough evidence to actually prosecute, but there was certainly an action plan coming out of that. And I just wanted to make sure that was being picked up by an appropriate committee, because I think we as councillors would certainly want to ask questions about, have we done everything that we possibly can to stop that from recurring?
I don't know. What does the rest of the members think on that? Because I don't think we can investigate an individual case easily, but I believe we can look at our what's being offered out there to control that sort of thing and look out for that as a general thing. Does that make sense?
Yes, absolutely. And I think you're right. You know, I don't think we can look into the details of that individual case. It's more around lessons learned for us, and whether there's anything more that we can do as the council to stop that kind of thing happening again.
And to be sure that lessons have been learned.
Yeah.
Yeah.
So who would that go to, Madeline? Who do you think we'd need for that?
Robin.
No.
Adult safeguarding.
Message.
Yes, next correct, adult safeguarding.
Well, let's get their opinion on that item. But yeah, add that to a meeting, see if we can find that, because that's quite an interesting one. I don't quite know how that particular one happened, but it'll be interesting to see that they are covered. Who do we got next? Adrian, did you have something?
Yeah, in terms of the forward agenda, I'm just thinking about, in the round, and feedback from Health Watch. One of the things is access to all levels of care, as it were. Do we have any sort of invite for GPs? Is there any GP organisation we can talk to?
Yes,
the answer to that. I was going to my hand was up to make a suggestion, a couple actually, just for your consideration. One's already been mentioned, but I was going to suggest CAMS, because we continue to hear about 2-year waits on the CAMS pathways.
Yeah.
So that's an excellent one. The other one I was going to suggest, which ties in with what you've just said, we had a very interesting video with a GP from Wargrave, who's the lead for population health management. And it was really interesting. So you could kill 2 birds with 1 stone then. So I could contact him and ask him if he'd be prepared to come along to one of the HOFs.
Yeah, what was the doctor's name?
Can't remember his name off the top of my head.
Okay.
Oh, you don't have to say now, but if it's something you're interested in, because he'd be able to answer, he could give you that, and then you could speak to him about other things, challenges they're seeing.
Okay, let's think about that one. That's more work for Madeline. Madeline, is that everything that we need to look at on the forward plan? Or?
I think Councillor Jones and Councillor Fryn have got their hands up. I mean, you've got a fairly busy agenda going forwards, but if members want to make any further suggestions.
Jim?
If I could say something, Ken, I'm just beginning to think maybe we need to put in a date for another meeting sometime towards the middle to the end of October. I don't know if we could have the council's response to COVID-19 on that, but certainly would like to. And also CAMS, and also the Health Watch stuff that we haven't been able to talk about tonight, and that seems like a fairly full 2-hour agenda.
We can certainly put not an unstructured meeting in place, I suppose. We wouldn't necessarily have all our regular items on it, but we could have an agenda for just one item if we thought that was going to be particularly heavy.
If we had those 3 that I've just mentioned, you've got an extraordinary meeting there. I know we seem to have an awful lot of extraordinary meetings for corporate and community, don't we, Guy? You're very good at having those. Maybe Ken needs a leaf out of your book.
I really do resemble Mr. Extraordinary Meeting, but not my power here. Not in my power here.
So you finished? Oh, good.
Yes.
Right. Yeah, we can look into that, see what we can put together. Madeline, another more work.
Chairman,
we've got to be careful we're not putting too much forward. Sorry, who's that?
Can I? It's Abdul. Can I come in? Sorry to interrupt you. We need to be very careful. We sometimes overlap things with overview and management scrutiny. So, if it's the same similar topics, we need to identify ourselves where we are heading rather than having, more.
Absolutely right.
Thank you, sir.
That's why I'm not committing to any of this until Madeline's gone through. We've also got to look at officers' times. It's all right for us to say, oh, we'll have a meeting on this, meeting on that. It may not be possible. Who are we up to? Alison, I just saw your hand up. Jim. No, Jim first, please.
Jim first.
Yeah.
Thank you. Madeline, we have an item on unscheduled ambulance response times. I declare an interest in this one. Is it possible just to get a report so we can see the stats and the trends on this without actually having it as part of the meeting, so we can actually read beforehand? just so we can see whether it's an item where we need to call people in to talk or not.
Yes, I can certainly request that.
If you could, I don't want to put too much on you, but if you could, that'd be brilliant. Thank you.
Okay. Nick, you just spoke earlier. Alison?
I just wanted to say that I found the sort of educative briefing on care homes was very, very useful. So, you know, other educative sessions I would certainly welcome, and, you know, to open those up to all members of the council, because, you know, we can't be over-informed, can we?
Yeah, no, happy to do that. Okay. Any other things for the forward program? No.
Actually, sorry, Ken. Yeah, I mean, I completely agree with Clive Jones that, you know, because of the COVID situation, we were in an extreme, unusual situation. Therefore, I think having an additional extraordinary meeting is warranted. Actually, I understand this puts additional pressures on Madeline and the officers, but I think, you know, we should be, you know, getting as much information as we possibly can on these topics. So I would definitely push for an extraordinary meeting.
Yeah, I think if you imagine we did have dentistry in for this meeting, crikey, I think we'd be here till 12 o'clock. It's quite long, so it's definitely a requirement, I think, for an extra meeting. But let's work that out, and we'll see what we've got available and whether the people are available for it. And then we'll take it from there. Okay, if there's nothing else for the forward program, then I will call an end to the meeting. Thank you very much for your time. Sorry, it did go on a little bit longer than planned, but like I say, it could go on later had it been needed. And I'll see you all next.
Thank you very much, Ken.
Thank you, everyone, and thank you.